Welcome to Think Like a Nurse, the video outreach of Keith RN. Today's topic is transforming nursing education. How to prepare your students to think like a nurse so they don't harm their patients in clinical practice. According to Dorothy Delano, who wrote in 2005, 2/3 of our current nursing graduates are unable to clinically reason at the most basic level to recognize a worsening change in patient status. This is commonly called failure to rescue and happens when the nurse does not recognize trends that reflect a deteriorating status change until it's too late. An adverse outcome or even patient death occurs. For example, when a patient slides into sepsis, but it's not recognized by the nurse until they're in septic shock, with severe hypotension and a lactate that's elevated and greater than 4, they will likely die as a result of this nurse's inability to clinically reason and think like a nurse. And if 2/3 of physicians were unable at the end of their educational practice and education to be able to diagnose patient status, that would be unacceptable. But in nursing education, that is our current reality, and I believe that is unacceptable as well. Is the traditional model of educating nurses that has been relatively unchanged for the past 40 years contributing to this inability of new nurses to transfer their knowledge to the clinical practice? In the book, Educating Nurses, A Call to Radical Transformation, Dr. Patricia Benner and her co-authors lay a clear vision of what must be done to change the paradigm of nursing education that has not kept up with the need to prepare student nurses to think like a nurse in clinical practice by emphasizing clinical reasoning. This article and this presentation is intended to be a brief summary of the highlights from educating nurses and what the Carnegie Foundation identified as needed change to change the paradigm of nursing education so that students are effectively prepared to practice at the bedside and what you as an educator can do to be part of this change. The problem is in the classroom, and that's where we need to put our energies and focus on really transforming nursing education. The clinical practice in the clinical setting does an excellent job of preparing nurses for what they need to know in practice, but the classroom is the problem. Number one, we have too much content in our classrooms. Nurse educators have a responsibility to emphasize what content is most relevant so students can acquire deep knowledge of what is essential for this specific area. But instead, textbooks are encyclopedic. And instead, we expect our students to know the entire chapter. And we burden them with burdens that break their back. And in the process, they do not acquire the deep learning needed to be relevant and to transfer their knowledge into the clinical setting. Dorothy Delano, who I cited at the beginning of this presentation, writes in A Crisis in Critical Thinking, although well-versed in content, the majority of our new graduates are unable or have considerable difficulty translating their knowledge and theory into practice. Why? The author believes that a highly probable cause is the emphasis on teaching more and more content rather than a focus on application of knowledge. A look at the size and plethora of nursing textbooks supports this conclusion. And I would heartily agree with Dorothy Delano and her conclusions. The second point that Dr. Benner and her co-authors make in educating nurses that we need to change in the classroom is that our content is not contextualized to practice. Practically speaking, our content is repeated from the chapter it was derived from, but we don't put a clinical scenario or hook to hang it on and intentionally apply our knowledge in most classrooms. Have we forgotten that students can read the content? And our responsibility as educators is to spend our time to contextualize essential knowledge to practice. Nursing is a practice discipline that takes place at the bedside. That's obvious. Therefore, all content must be intentionally situated to show how it impacts patient care at the bedside. But this is not done consistently, to the detriment of the deep learning that our students must have to transfer their knowledge to the bedside. The third point that Dr. Benner makes in educating nurses that must change in the classroom is that PowerPoint-driven learning is the norm, but it doesn't engage students with clinical realities. Benner states this best. She says, classroom teachers must step out from behind the screen full of slides and engage students in clinic-like learning experiences that ask them to learn to use their knowledge and to practice thinking in changing situations. Again, the essence of clinical reasoning. Lecture and PowerPoint-driven presentations are very passive pedagogy. Only 5 to 20% of content is ultimately retained by the student. After only 20 minutes in the classroom, students begin to disengage and nod. The role of the student in this passive environment is simply to absorb knowledge, take notes, and passively participate. And this does not promote the deep learning that is required by our students. But instead, we can make the classroom an active environment and use active pedagogies must take place. For example, if you use clinically derived case studies that emphasize clinical reasoning, you can engage learners, and up to 50 to 75% of retention can occur in this environment. Students actively participate. They experience the essence of the clinical context and construct and apply their knowledge. What classroom would you rather be in? I know which one it would be for me. Dorothy Delano again weighs in on this topic. She says this: recall and understanding of content or selection of the correct answer does not equate to clinical judgment. In the real world, patients do not present the nurse with a written description of their clinical symptoms and a choice of written potential solutions. Smart nurses are effective nurses when they think critically, not when they can pass multiple choice tests. The fourth point that Dr. Benner makes that must be incorporated to change the classroom is that classroom theory is currently fragmented and poorly integrated with clinical practice. Currently, in most programs, classroom theory and clinical education are in their own separate orbits with little to no intersection. We have classroom theory content in this circle, and then we hopefully will transfer that knowledge in our clinical setting, but yet we don't intersect these circles of knowledge and context of practice to promote the learning that our students so desperately need. And I would say that thinking is a skill that must be practiced. And what better place to practice nurse thinking than in the safety of the classroom using clinically derived clinical reasoning case studies. If the content isn't covered in the classroom and it's not applied in the classroom, the opportunities to apply it are totally random in the clinical setting. As you know, patient assignments, you may or may not get a good patient who will reflect the knowledge that your students need to really apply their knowledge, and therefore we're leaving it totally to chance. But if we intentionally integrate clinical reasoning case studies that are clinically derived in the classroom, this randomness no longer happens, and every student will get the opportunity to engage and practice their nurse thinking so that they too can learn what it means to think like a nurse in the clinical practice of nursing. So that is our topic today. Our next topic will be on the solution and how we can be the change, which is really what I am about and what my website is all about as well.